Good evening, everyone. Welcome to this week's virtual Global Spine. I know it's evening or late night for those in the US and Europe, and in Australia it's early in the morning, and my team's just getting a case set up. But this week we are discussing various methods of performing L5-S1 anterior lumbar interbody fusion. So pretty specific topic, but I thought this would be entertaining. It's a fairly common operation. Now, I met Samir, Dr. Samir Smajic from St. Joseph in Germany online. So I never met him in real life. And then we were both on faculty at the recent N-Spine meeting in Strasbourg and Porto. Absolutely brilliant meeting. And I got to see what a brilliant surgeon and thinker Samir is. He really knows what he's doing. And he's got an amazing technique of doing L5-S1 and the lateral position, which I think is worth discussing and talking about. We've got a sort of little debate happening, but I'm going to let him lead off first. I'm going to let him sort of get his shots in, and then I'm going to just fire a few small ones back for the traditional side of things. But it's it's a great topic. Feel free to ask questions, interject. It's a very open format, and we'll go from there. So I will ask Samir, actually, just before he kicks off, I'm going to ask Samir if he can tell us a little bit about the patient he saved on a plane on our travels around Europe during his tour. But that may, he came to the aid of a passenger in need, which was quite amazing. So he's a very qualified in-flight doctor if you ever have to get on a plane with him as well. So I'll let him kick off.
Hi, my name is Samir, and I'm happy to be here and to share some experiences and to try to battle one of the best maybe anterior surgeons which I know, and but I think it will be a very interesting topic. To come back to this flight which we had from Strasbourg to Porto. I'm a little bit afraid of flying, and when this happened during the flight, somebody screamed in the back of the flight, and I didn't want to look to the back of the airplane. I just saw all the spine surgeons in front of me, all the perfect scoliosis surgeons. I don't want to tell any names like Firuz or Mike or whatever, nobody stand up, and everybody was looking to the back maybe 5, 6, 7, 8 times. And after a minute, I thought I should have a glance what's happening in the back of the plane. And I saw a woman, she lost her consciousness. So I stand up and walked over and did some first aid, which I learned in Germany as a trauma surgeon. And I was really surprised that the American and Canadian doctors were a little bit, let's say, cautious about helping. So it wasn't a big deal, but very funny for me.
We were all in like sardines to me, I reckon. It was pretty hard for some of us to move. But luckily, we found a French-speaking doctor for the patient.
French-speaking doctor, yes. So the women, she could only, or the guy next to her spoke only French, and we had someone who speaks French, and I was calling the French-speaking doctor, who was one scoliosis expert from Canada. So it was very funny. But nevertheless, we start with this topic, with my presentation, with my speech. It is about anterior anterolateral access to the lumbar spine, to L5-S1 in particular. We know the traditional accesses to the lumbar spine. We know XLIF or ALIF or OLIF or ILIF. You know these procedures, but what is an lateral anterior ALIF? Is it an OLIF or is it an XLIF? What is it? In fact, it is a classic anterior ALIF, but only the patient is positioned in the lateral position. So this is an ALIF. So to be clear, it's not an XLIF or an OLIF. It is an anterolateral cut. It is a minimal invasive procedure. The cut is 4 to 6 centimeters long, and even L4-5 is accessible. This is how it looks like. The patient is positioned on the right side, for example. So we make some preparations, making some paintings on the patient to have a better orientation where we are. The middle picture is very interesting. As you see, when the patient is lying on the side, the belly and the organ and the colon and the peritoneum falls down, and we have a space which is very safe, similar to the Olaf procedure. This is the anatomic picture or the anatomic way to the lumbar spine. The L-Aleph. L-Aleph is described here in this particular way by Bodon. He's a doctor from Hungary, and he's a very good spine surgeon, and he made this anatomic cadaver tests, not tests, anatomic cadaver surgeries, and made beautiful pictures which shows us how to get to the area of interest. You go through the muscles, you split the muscles, you don't cut the muscles, you don't cut anything. In fact, you are splitting. It's a splitting technique. And on the right side, you see the anatomic structures which are in the way of a spinal surgeon. So which we have to be aware of. Here is a nice picture and a very nice overview, a CT scan in the supine position and a CT scan in a lateral position. The lateral position CT shows us the same what we saw in the pictures before, that there is an excess between the source and between the peritoneum towards the L5-S1 region, similar to the Olaf. But as you can see on the retractors on the left side, we have a straight view to L5-S1, not an oblique way. The patient is positioned on the right side, for example. You can do it on the left side as well, but in this case, it is on the right side. You fix the patient with a lot of tapes until he doesn't move anymore. It takes a little bit time in the beginning to position the patient, but as you have a good orthogonal position, you have a very easy approach. Here are the paintings on the patient. You see on the top of the lateral lumbar region, you see how I painted the vertebrae L5 and S1. You see there's a small slip maybe, and you have a super overview because during surgery you see all the time your paintings. So you're not searching anywhere around, you're going straight to the point of interest. Here you have some pictures of the procedure itself. You see a 5 centimeter cut on the left side. In the middle, you see the aponeurosis. You see there's no real cut. This is a splitting technique. You see the muscle. Here you can see me sitting during this approach. I bend the table a little bit. For me, easier to look to the patient, but only 10 degrees. This is what I have adopted in the last year. Here you see some deeper cetus pictures on the left side, the splitted muscles and the splitted fascias. Then you see the beautiful the beautiful view on the discus L5-S1 with the central sacral artery. So as you can see, you have a really good view as you know it from ALIFs. Here are some impressions from other surgeries. So it's not only in one surgery possible to do this, it's possible to do in a lot of surgeries. And as you can see on the left picture, the blade is 180 millimeters long. So even obese patients, you can easily come to the right side. As you see, the blade is on the right side. Some more impressions after implanting a cage, and you can see on the left side the tool, how the cage comes in. It is orthogonal. It is like an ALIF and straight way of putting the cage into the patient. Now I'll show you some pictures how it looks like the post-operative results. So on the left side, we see this huge enterolisthesis, and we see the nice reduction on the right side. You see it's a percutaneous technique. As you see the rods in percutaneous technique, and it is all a passive decompression of the spine. So as you can do it in an ALIF. But you can do this surgery in a single position. So if you want to, you can put the screws from the back and you can work simultaneously. I do it sometimes. In this case, I didn't do this. I didn't need it. But sometimes you need to get more lordosis because the facet joints are blocked or whatever. But in allostasis cases, it's not a problem. Here you can see one big benefit. The surgeon is sitting. So in which procedure we can sit in spine surgeries? We always look after the hand surgeon and say, why am I not a hand surgeon? My feet are aching. So this is something nice for us, an option. And we can do really good reductions, as you see. Even obese patients like her here in this case is possible to do an ALIF without a big deal, a bigger deal than an ALIF, it is not. So the spine surgeon sitting is for me very important because I can sometimes, if I'm tired or over a year working, I put these surgeries in between to get some rest. So an ALIF can be a rest surgery. This is the sliding cage technique. So you can do it in ALIF as well, but I just wanted to show it. You fix the cage in, let's say here in the os sacrum, and then you can percutaneously make the reduction sliding over the cage and have a nice lordosis. You can put the screw even in L5 and make the sliding technique, sliding cage technique, I would call it. This is more a fixed cage and sliding L5 technique. Extended indications for this kind of approaches are you can use in one single position several cages. You can combine XLIF or lateral lumbar interbody fusions and ALIF in one position. So it is comfortable. You do the anterior ALIF, L4-5 in this case, L5 is 1, and then you do the XLIFs, you know, very, very easy and very fast. And you do the first surgery, like the first step, half sitting, half standing, and the next day or the day after, you do the percutaneous instrumentation. Extended indications are, as I got more experience, I felt very comfortable to put even prosthesis in this kind of position. So this shows you can really make a far discus release. So it's not a small oblique OLIF, it is a big ALIF procedure. And what I really like is I can use the X-ray the whole time. That means the X-ray can be above the patient as I do the surgery almost alone. I can put the kerosene into the up to the to the ligaments, and I can see where my kerosene is, and I can easily make the decompression of the lumbar spine. So this is a really good let's say tool, having the X-ray all the time in lateral position. I don't need it, but in some certain circumstances, in the compressions, it's beautiful. Extended indication can be even two-level prosthesis, or you can even make a single position hybrid surgery. So that means you can do the L5S1, but if you need to, in the same position, you put an X-lift and the screws. So I think this is a very charming technique. What kind of complications do we have? We have similar complications like in anterior, in the classical supine surgeries. And it is, let's say, the complication rate is not so often because we really do a lot of L5S1 surgeries and not too much L4-5. And L5S1, we have easier anatomic situations, so we have quite good outcomes regarding complications. So what is it? What are the benefits of an lateral anterior X-lift approach? The benefits are, for sure, same possibilities like a classical A-lift, classic A-lift in L5S1, plus surgeon sitting, plus lateral X-ray the whole time, plus obesitas, easy access, plus one surgeon only surgery possible, plus single positions 360-degree surgery, plus extendable single position lumbar interbody fusion, and plus single position hybrid solutions. Thank you. That's my talk about this topic.
Wow, Samir, that was very good. That was very good. Thank you, my friend. That was amazing. I think that technique has so much to offer, and I think one thing that I suppose, looking at it as a relatively experienced anterior surgeon, I think the equipment that you have for it is really important, like the retractors and that. Did you want to just, I mean, we're not here to name names, this is a non-sponsored event, but I think you use some of the invasive gear, is that right?
Actually, I only know two companies who can offer this kind of solutions, and it is invasive on the one hand, on the other hand, it is Globus Medical. And
Globus, okay, yeah. Because I think those retractors are super important. Like, I couldn't see myself being able to do this surgery with a standard A-lift retractor, ring retractor, or Thompson type frame.
No, I have tried it, but it's quite difficult, I have to say. You know, you need this, you need two arms. One arm is flexible from down, and you can put the belly down with the one arm. So a little bit left, a little bit right. And this is very important to have a flexible one retractor arm and a half retractor on the other side. This could be Thompson as well, but the lower retractor arm, one arm, this is the most important thing.
Yeah. And do you think having the ability to get lights in there really helps as well? Those bladed lighted retractors?
I didn't get you.
So you know how you can put little lights on the end of retractors? Do those ones have lights on them as well?
Yes,
like your,
yes, they have lights. I don't need glasses or a microscope. I have these lights. It's like with a lumbar, lateral lumbar interbody fusion. You see everything. You have seen the pictures, enlightened discus. It is unbelievable good view.
Excellent. All right, Samir, I'm just going to have a look at the chat. I don't think there are any questions at the moment. You've blown everyone away. Is there any of the faculty online that want to fire off a few questions while I get my talk loaded up? Let's see. No, they're all stunned at the moment. Okay, they might fire in later on after I get this going. So I'll just see if we can get this done. All right, can everyone see that okay? Samir, you got that?
Yes, perfect.
Good. Excellent. All right, so this is us going head to head. It's a very friendly head to head. I'm from Australia, where there's a lot of bad stuff. So we're used to, quite aggressive things, as demonstrated by this map. Lots of problems down here in Australia. So we're dodging dangerous situations all the time, and that's what ALIF is. I mean, it's a beautiful operation, but it is a dangerous situation for us, I think, in terms of the vascular anatomy, bowel nearby, ureteric anatomy. There's a whole bunch of other things there that we just got to be so careful with. But this is Samir and myself at Spine having a dinner in between the 15 talks that Bronick asked us to do each. And then Germany are very, very good at association football or soccer. They beat Australia quite easily almost every time. We just beat them in basketball. But the most important competition is who has more LinkedIn followers. And unfortunately, I'm losing. So onwards. When I'm talking about L5S1 ALIF, what I'm looking for is really an approach that allows me to put in a very large cage safely and get good end plate contact. But the vascular anatomy is what stops surgeons from doing this approach, particularly themselves. In certain parts of the world, access surgeon is mandatory. I cut my teeth doing these approaches by myself. Or with other spine surgeons, but interestingly, I sort of transitioned to doing about 2/3 of these now with my good friend who's a general surgeon. I just find it moves quicker, and that we're able to deal with any complications that arise. So this was a patient in his mid-60s with L4-5 degenerative spondylolisthesis and an L5S1 disc degeneration, some subtle other changes throughout the spine, but the primary pathology is at the base of the spine. And on the right side of screen there is his anatomy over the front of that 5-1 disc. Now, that's from my operation note. And as you can see, we had a little tear in a vein that bled a bit. We lost 350 mils total, and it was a 4x1 millimeter split. But if you look here really closely, the iliac vein is bifurcating there to the internal iliac off the common iliac already at the mid portion of the disc. So that's actually, and that was highly adherent, right? So I know there's patient selection involved with this, but to me, going lateral on this would have been almost technically impossible, although I recognize Samir may be able to do it. And then I wonder if you get these little splits in the vein, and certainly this wasn't a disaster, it was easily repaired, but I wonder if that is as possible through that lateral approach. And this was that chap's filmed after surgery, and he's done very, very well. Improved his sagittal balance, improved his spondy and his regional and global alignment there, I think, in the lumbar spine. So the vascular issue to me is one that is always forefront in my mind, particularly as I've had to repair them myself before I invite my friend along, and it's a scary, scary proposition. I'm going to put in a little plug for the hat I'm wearing. Again, not taking any money from them, but it's a great course that they run every year in Europe, and you can learn how to repair blood vessels there from some masters of vascular surgery, and it's a very, very, very valuable course. Live tissue training and cadaveric training. So I think the supine advantages to me is that you get potentially better vascular access, and it is extensile if there's a disaster. I think a big thing for me is you can release the PLL very comfortably and easily. And you can easily then access posterior disc material. I think it's easier to put on a large, strong plate, particularly if you're doing standalone. You're not working as obliquely, and you don't need to be as reliant on integrated cages. And I find that flipping doesn't take that long. And the other thing is, I think there's the heap of data now that the prone position also helps lordosis a bit more. So what's this? This is a decent sized fragment of disc that I pulled out from behind the PLL going into the foramen after I released the PLL from an ALIF approach. And so this is the kind of thing you can retrieve just like an ACDF with a little bit of distraction across the disc space. Getting videos down that space is a bit hard, and one disadvantage of supine ALIF, videos are definitely easier in the lateral position. But this was the case that piece of disc came from a lady who'd had a T5 to L5 big previous posterior spinal fusion. And she's now developed a quite significant adjacent segment disease at the base of the spine. And this is her here. She has a collapsed disc with a big foraminal bulge and severe right leg radiculopathy. And so she had a classic supine ALIF with me. We got that fragment out, we reconstructed her. And this is where she went. She had that surgery 20 years ago. So going to L5 in her certainly wasn't a disaster. It lasted her, well, 20 years or so, but we managed to use a 25-degree hyperlordotic ALIF there to kick her back into alignment. Now, the other point with these hyperlordotic cages to me is that unless you take the PLL or significantly loosen it, when you put in a hyperlordotic cage, you can end up pivoting around the PLL rather than actually really opening that back of the disc space up. I think that's very important. Just another case. So this is a young lady with isthmic spondylolisthesis, and she's got a spondy at L5S1, and you can see the lying MRI. There's very minimal listhesis. There's no major central stenosis. She has bilateral foraminal stenosis. You can see the EOS scan on the left, that there is a definite degree of instability there between the lying MRI and the standing EOS scan. In this type of circumstance, I see no point in doing additional flexion extension views. However, she's got a bone scan with SPECT picture there as well. And the reason I use that is because I know 5-1's the problem. So I'm not trying to prove that. But I've been burnt by doing a few of these cases in patients in their 30s, 40s, 50s, where they've had a significant 4-5 facet joint arthropathy that I've missed, and they've had ongoing pain after surgery, and we've had to extend up a level or do facet-based interventions. And so I like to have that knowledge before I go in and fix these cases, and I use bone scan with SPECT for that, and sometimes even diagnostic blocks in the 4-5 facet joints. So for these kind of cases, I've got a little algorithm of patients that are appropriate for standalone fixation. It's usually low pelvic incidence, grade 1, isthmic spondylolisthesis, good bone quality, young, appropriate vascular anatomy. But I like to use separate cage plate constructs. I feel their failure rate is much less. It allows for some micromotion and settling of the cage without interfering with the integrated fixation. And I do worry a little bit about the ability to get a plate on like this through a lateral ALIF approach. But Samir can again probably prove me wrong. And that's a follow-up scan. That was a 4-month CT, and she's almost solidly fused with just a standalone approach there at 5-1. So I think that plating to me is important, particularly for the standalone cases. Yeah, I've tended to shy away from integrated cages, but I'd be, after a few bad experiences 10 years ago, but I'd be very happy to hear others' thoughts on that. It's a good discussion we can have. And then finally, you know, the flip, we all worry about the flip or you know, not being able to do things, but we do know, and I'm just going to run this in the background, that we get more lordosis out of the prone position. I think there's multiple publications on that, and we're moving towards prone lateral surgery a lot now. And I know Samir likes prone lateral surgery for the very reason that you can create a bit more lordosis positionally. And this is a little time-lapse video of us flipping a patient, and you know, of all the, you know, things that we can do, you know, opening trays, etc., takes a long time. This takes 12 minutes. So it's not a big deal for me to flip a patient and get that extra couple of degrees of lordosis that that technique can allow. So I've gone through my bit there. I'm going to open it up. I've got some other individual pictures and other things. I'll stop sharing for now. and see what Samir has to say in response. We'll see if we can get some questions from the audience, and I've got a bit in the chat box to look at.
I'm really amazed. You really do beautiful reconstructions of the lordosis, and your approach is quite bigger than mine, and you have a better overview, I'm sure. But you can, even through small approaches, put big cages or plates. But I'm not a fan of plates, to be honest. I do screwable cages and the posterior fixation. It goes well. I take usually material from the iliac crest as I'm there, close to the region. I can do it when I do the ALIF. I can go into the iliac crest a little bit, take some a little bit bone and blood. And that's why it usually fuses very well. But I have to say, I wouldn't change the technique when I had this table. What you have, your table is great. You can switch the position really fast. But we, in normal circumstances, we have normal tables. It takes a lot of more time to change the prone position, and somebody has not big surgery rooms. They need to open the trays, and everything is always a matter of how you are equipped. And I'm sure you are really good equipped. And at the end of the day, the results are the most important thing. And I think you're very comfortable and you do very good surgeries. Great.
Well, thank you, Samir. I mean, I think your approach is brilliant, actually. And I suppose I really like it. And I think it's an awesome approach. And I'd actually be quite happy to do it. I want to give it a go, right? But, you know, I suppose the important thing in your approach is that, correct me if I'm wrong, but you are effectively your own access surgeon. So you're very experienced in that space. That'd be fair to say, right? And so I think that this is an approach that, number one, if you haven't done a lot of them before, you need very careful patient selection, particularly watching that iliac vein. And then you've got to build yourself up to get good at it. Would that be fair to say? You know, you start with the simple cases, like all things, and move up. And I think you probably don't want to operate on a very large patient with a previous surgery at L5S1 and an iliac vein that's draped across the top or bifurcating over the top. You know, as your first case, right?
Yeah, as your first case, of course not. It doesn't matter which, if you do it in supine ALIF or in minimal invasive lateral anterolateral ALIF, you need to start with the easy case. You need to have a huge, very much room, far away from the iliac veins, no osteophytes, no previous surgery, whatever. Very thin person, so you should start with these kind of surgeries. I recommend to learn first the classical ALIF, because you have to have security about the anatomic view, because the anatomic view changes in lateral position. So you have to know the cetus when you do the surgery from the lateral side. So the cetus falls down, and even the iliac veins fall down. So usually when we do the supine ALIF, we have more problems to go to the right side. The obese as the patients are, we have more problems to come to the right side. We need to work more, be careful, get the blades over there. Like we have more problems with the right side. So when we go from left. So when we have the minimal invasive lateral anterior access, we have more problems with the left side, because the iliac vein falls down like it falls down the peritoneum and everything. It's very easy to come to the right side, very easy, even in obese patients. So so you have to take care about the changing of the anatomy. So when you start with this lateral anterior minimal invasive approaches, you cannot only look at the CT and say, this is the CT scan, so this is the anatomy. I showed in my presentation, the anatomy changes in the lateral side. So you need experience to be, first of all, an anterior surgeon from the classical supine position. But later, it's really interesting, even for you, I'm sure. If you sit, this is beautiful. You know, like we have to do this work until we are 60. You know, like, and me and you, we are, let's say, a little bit stronger, and our feet have to hold us. And even when you need a 2-level anterior access, you need 90, maybe 2 hours, maybe sometimes 3 hours. It depends on the patient. If you have an access,
I think not craning your neck is good.
Yes,
the neck not being down and this sort of angle is nice as well.
You have
Yeah.
this thing on your head, always loops, and this is all heavy. And this is more comfortable surgery. I'm sitting, you know, like it is like king's surgery, I call
it. Hey, we've got a couple of questions on the chat box, Samir. We've got Dr. Baessa, who's a regular participant, just saying, is there any difference in retrograde ejaculation between ALIF and OLIF, like in terms of percentage? I'll lead off. I have not seen retrograde ejaculation in my practice pretty much ever. I have wondered if it's a BMP dose thing and a transperitoneal versus retroperitoneal approach issue. I do a retroperitoneal approach, and so I mean, maybe I'm not asking the right questions, but the younger males who would be affected, I do just double check with them, and I haven't seen it really much at all in the retroperitoneal approach. But I know it's a concern. And you know, I do wonder if some of the papers in the past that have commented on it, particularly with BMP, have been as much due to a transperitoneal approach as the BMP being used. Yeah, Samir, what do you think on that issue?
For me, it's a very important issue because I have a lot of young males for prosthesis surgery, so I have to open the whole discus from the left to the right side. So, but up to now, I had not even one patient with retrograde ejaculation. The technique which I use is the technique which Professor Halm used to do it. I learned from Professor Halm, and he was, you know, you have to push. You have only to push the plexus, not using bipolar, only for the central sacral artery. But for all other things, just pushing the region. When you do an OLIF, you see really nothing. You're just pushing. I don't know. I don't do OLIFs in L5S1, but I can imagine you can make more trouble because you cut before you can push, you know, the plexus away.
Yeah, agreed. There's another question from Wana Maya. Is there more difficulty while preparing the end plates for the cage or when dissecting the peritoneum? So, you know, in that lateral approach, do you have any, you know, peritoneal issues or end plate issues? So it's really two separate questions, Samir.
Peritoneal issues I have had in the beginning, to have a tear or whatever in the beginning, but until I understood the anatomy, I haven't had the problems with peritoneum at all anymore. Preparing the end plates can be sometimes difficult on the left side, even if I go through the left side because of the left iliac vein. It can be sometimes a little bit difficult. So I have to take care, but I usually use a shaver, small shavers to go behind. Sometimes the vein falls too much down. I go behind and shave very, very calmly the edges away and then use keratins. But on the left side can be sometimes difficult, yes. On the right side, never. I can clean it up very easily.
It's very, and I think to me, one big advantage of the supine ALIF, Samir, is your ability to use fluoroscopy quite freely, which is trickier in an ALIF where I just tend to get spot check fluoroscopic shots. Let's see, is there any more questions coming through on the chat? And we got some faculty on, but I think they are all a bit scared by what we're discussing here. All good. I've actually got another ALIF case to show if people want to, if we want to have a quick look at it. I don't know, Samir, if you've seen this one. I'll just put this case up, and is a super interesting case. So let's see. Sorry, screen share this. All right, so this is a lady who's in her mid-60s, who 10 years prior to me meeting her had had quite a few spine surgeries. And I think you can see on the rightmost image, her thoracic spine is entirely ankylosed, and that's from scoliosis surgery using Harrington-type rods, subsequently removed as a teenager. And she got some adjacent segment disease and ended up with having a single segmental fusion at the level below, kind of done in kyphosis for adjacent segment stenosis at the distal junctional level. And this was all done by a series of surgeons in my local region here. And she came to me, so this is a film from 10 years ago. And at that stage, she was seen by another surgeon who thought she was likely to benefit from a pedicle subtraction osteotomy and removal of those implants, and then proceeded with this surgery, which is essentially a T, I think it's T9 to L5 posterior instrumented fusion with a asymmetric PSO. And these are her immediate post-op films. So her PSO was done at L1, and that was the degree of correction obtained at the time. So she did okay for a couple of years and then came back with quite severe pain, and the CT is a bit out of phase, but you can see on the left there, she's got a whole bunch of bone forming at the back, relatively solid fusion. A few of those screws are a little bit out, unfortunately. But you can see they've said there's no significant cause for the patient's pain on the radiology report. If you look at that disc at L5S1, it's become really quite abnormal. It's sort of become enlarged and almost like a Charcot type joint. And then this is how she presented to me. So in summary, she's had Harrington rod fixation. She's still got an upper thoracic kyphosis. She had a short segment L1-2 fixation beneath that, and that was converted to an L1 asymmetric PSO with a T9 to L5 fusion. And this is a really tricky situation. I think you can see her SVA is huge. Samir, how would you take this on? What's your plan?
I would tell her there's a good surgeon in Australia. I know him personally. You should visit him. He's crazy enough to solve this problem.
Yeah. This is a challenge because she's still relatively young, and you know, she's got really a multi-level deformity. I think she's got residual deformity within her fusion mass, and she's got a few screws a little out. She's got upper thoracic deformity, and she's got that lumbar deformity and grossly positive SVA with complete collapse of that 5-1 disc in the erect position. So, look, she was for me a good one for supine ALIF, and you can see here reconstruction that I managed to get done. So we did a supine ALIF with a 25-degree cage, needed a bit of templating because we're right at the maximum heights of this particular device when we came through with that one. And then for this one, I used really short and small screws at the front so that I could clamp down a bit more at the back. I find these anterior plates are only robust when you get long 7mm type screws in, and you still get a bit of flex at the back, even with a 4
whole plate with all screws in on it. And then we had to flip her to the back and do an L4 PSO to get her lumbar alignment approximately correct. Now, she's still got upper thoracic kyphosis and cervical stenosis that I'm going to have to deal with, but she's getting over this surgery, and then we'll look at the upper part after that, remembering that she is fused up to T3 in her thoracic spine. So that was a nice direct ALIF. And I think with this one in particular, I've managed to completely release the PLL to get that big cage back there. So very, very helpful in that particular scenario, being able to look directly down. Look, I think if we don't have any other questions, I might have to, we'll wrap it a few minutes early. That was, we've got through pretty quickly there, Samir. Any of the other faculty on that wanted to make any comments? No. All right, well, we'll let you get to bed, Samir, because it's late at night and I'm sure you got surgery in the morning. And yeah, I've got a case to do now. So we'll wrap it up there. I thank everyone for joining us again. And I think next week, Nada is on. He couldn't join us tonight, and he will be presenting some of his interesting trauma cases. But we will tell everyone on Twitter and LinkedIn during the week.
Thank
Thanks
you very
again.
much.
Thanks all.